Yasmin?
Mushtaq, I have
join
joined.
করেছেন হ্যাঁ জয়েন করেছেন
Oh, Ziller, you are here.
Yes.
Thank you.
Yes.
Let's start. Okay, so
আমি করেছি
hello from Dhaka. This is Mushtaq Chaudhry. I'm the convener of Bangladesh Health Watch and also the moderator for this webinar. On behalf of the Bangladesh Health Watch, I welcome you all to this webinar, which is titled Future Health System for Bangladesh, the Case for Universal Health Coverage. Ladies and gentlemen, the COVID-19 is the greatest threat to human health and to human civilization in over a century. Fortunately, it is showing early signs of slowdown in Europe and most of Southeast Asia. But it is still raging the rest of the world, including Bangladesh. As we struggle to combat the disease, the COVID has drawn our attention once again to the weaknesses in our health systems. These include inadequate and incomplete surveillance and data systems, neglected primary health care, shortages of human resources of all categories, lack of essential facilities and equipment, and necessary drugs. Add to this are the issues of governance, health management, and poor budget. As the saying goes, never let a crisis go to waste. The COVID crisis has set the ground for a new health system for Bangladesh. The government of Honorable Prime Minister Sheikh Hasina is committed to implementing universal health coverage in Bangladesh. But unfortunately, this has remained unimplemented so far. Our hope is that the COVID crisis will give the government enough impetus to implement universal health coverage for everyone so that no one is left behind and no one is denied quality health care for being unable to pay. To discuss these issues of COVID-19 and the future of health systems for Bangladesh in terms of universal health coverage, we have today a very distinguished panel of national and international experts. This session, we are so pleased, will be chaired by Mr. Ashadul Islam, who is a senior secretary to the government of Bangladesh and a champion for universal health coverage. The other designated speakers include Dr. Mohammad Shahidullah, who is the president of Bangladesh Medical and Dental Council, and also the lead for the Technical Advisory Committee, National Technical Advisory Committee for COVID-19. We also have Mr. Robert Yates, who is the Executive Director of Universal Healthcare at Chatham House in the UK. Dr. Fahmida Khatun, who is the Executive Director of CPD, the Center for Policy Dialogue, and Dr. Hussein Zillur Rahman, who is the Chairman of PPRC and BRAC, and a member of the former caretaker government. Before we request our first speaker, here's a quick introduction to Bangladesh Health Watch. As you many have heard, the Bangladesh Health Watch is a civil society initiative which was started in 2006. The purpose of Bangladesh Health Watch is to monitor progress towards good health for all of all Bangladeshi citizens. Ladies and gentlemen, in the audience today, we have, apart from the Bangladesh Health Watch members, representatives from the government of Bangladesh, the civil society, NGOs, media, academics, and development partners. We are also joined by many participants from outside of Bangladesh. A big thank you to all. Before I start, here are the ground rules. Please keep your video and microphone in mute condition all the time, except when you wish to speak in the designated time period. So without much ado, ladies and gentlemen, let's move to the main webinar program. Now it is my great pleasure to invite the first speaker, Dr. Mohammad Shahidullah, who is the lead of the National Technical Advisory Committee for COVID-19. Dr. Mohammad Shahidullah, please.
Thank you, Mr. Reza Chaudhary Bhai. I'm very pleased that I have been invited to this particular meeting. But I would say at the very outset that my net is actually giving some trouble. So I don't know how far I will be able to speak without interruption is a question. But then I think I like to thank the organizers, particularly convening this particular webinar meeting in a pandemic crisis where Bangladesh is also struggling with. Now, with a very small background that I think you have also made, but I would suggest, I will say it again, that Bangladesh, in a geographical, if I talk about the area, small land with a vast population and the highest population per square kilometer. And when it is in one hand, the other hand, we have got the per capita income, which is only hovering around 1900 US dollars. Now, saying all these things, what I want to say that since our independence, the health sector has grown very slowly. But I will draw everyone's attention that it has grown mostly on ad hoc basis in a piecemeal manner, never in a holistic approach. And therefore, the decisions and the policy which were taken sometimes actually didn't actually have, it was not planned in a way that how the country should build on and what will be the health infrastructure eventually will be. And we had actually, I am very sorry to say that we had, the well-planned decision about the health service infrastructure, then human resources, logistics, and the use of procurement heavy equipments was never been in place in that way. And particularly emergency health situation management and pandemic crisis is beyond our imagination. So, and with that background, we are now in the COVID-19 crisis. Now, this sudden appearance of COVID-19 crisis has put us into multiple challenges. I would just draw attention in terms of, that particularly in this crisis, one is actually the testing, the number, the quality, and its robustness. And we are having multiple challenges to cope that. And then is about the other issues, health service, that if somebody is detected, then question of quarantine, isolation, and those who suffer needs admission, they need hospitalization. And these all have put us into a great deal of challenges. We have not adequate number of beds, and also the absence of management. But again, that's not for Bangladesh. Every country in the world have faced the same challenges, particularly with this disease, this corona and COVID. And they are also learning. So from that point, we are not much different from many countries. Now, again, in this crisis, we have actually seen that we have the number of healthcare providers that we need is not adequate. And particularly in many situations, particularly those who need high dependency unit care, ICU care, we are seeing the shortage of manpower. So these have exposed our weakness. Then again, about the, if I talk about the human resources, that the doctors, nurses, paramedics, cleaners, besides the number, is their knowledge, skill, training, roster. These have all become great challenges. Another one challenge which we are facing is the absence of networking of the hospitals. It was there in many developed countries back from since 50 to 60 years ago. And I worked in Australia, it's about 20 years back, 28 years ago, where the networking of the hospitals or regionalization is there. How does it help? Because once you are full, you know that what are the hospitals that can accommodate the patients. And in the absence of this networking, what we have seen, that patients are actually moving from one hospital to another hospital, not getting management and having a lot of suffering. And unfortunately, we have noted some deaths as well. Also, we have seen in the COVID crisis, the oxygen supply system, which would have been there in most of the at least well-established hospitals. It is weak and sometimes it is absent, particularly the plants. So the other issues regarding health service, I would mention that which has been exposed during the COVID crisis is the other investigation facilities, particularly radioimaging. So these are the challenges, and these have exposed the weakness and the gaps in our health system. But as I said, this is not true only for Bangladesh. This is true for many other countries as well. So now, based on the above facts, I want to say that our learning that we have, or in other words, what we have learned from this COVID crisis, I will say in broad headings, 5 points. Number one is the ad hoc and piecemeal decisions and health measures, which has been a practice in this country, has put us into challenge. And from now onwards, we need to have a holistic approach. And for that, health sector reform is very crucial. The second point that I want to mention is that country context decision has to be taken. Sometimes we follow the prescription of the donors or the international agencies, and sometimes we do not see a very good result of that. So people are there, we need to take our decision based on the country context. The third issue would be whatever we do, we have to think about the sustainability, we have to think about the quality, we have to think about the equity, and we have to think about the gender. And we sometimes see that there are actually gaps in these particular 4 sectors. The fourth is when you have in a normal situation, in a routine business, then it is one thing. But you need to prepare for your disaster during the disaster. So in the health sector, disaster preparedness is also an issue that we should keep in mind. And lastly, that I want to say that the poor health budget, which I have been seeing for a long, long time in this country, I mean, it's a great challenge. This COVID-19 crisis has given us a kind of a learning or opened up our eyes that spending money in the health sector is actually a key to the development of the whole country. Otherwise, we can't. With that few words, I'll end here. Thank you very much.
Thank you. Thank you, Professor Dr. Shahidullah. That was very nice introduction to the whole webinar today, and your candid opinion on the kind of situation we are passing through. That's very important and very nice. Thank you so much. Now we have 10 minutes of open discussion on the current situation. And it's my privilege also to start by inviting Professor Shah Monir, who is a member of the government of Bangladesh advisory group on COVID-19. And Shah Monir was also the Director General of Health Services in the past. So Dr. Shamoni, please. If you please speak for 3 to 5 minutes. Thank you.
Thank you very much for inviting me, and it is a privilege for me, and it is a wonderful sessions that you have organized. As all of you know that with the experience of the COVID-19 shock, the whole globally as well as nationally, we now have to think twice how to improve the health systems in the country. In Bangladesh, actually, we need to work now very strongly the how to reform the total health systems with a strong good governance and others. But if somebody asks me, what is the scope of mandate of health services in Bangladesh? I don't find any answer very clearly anywhere. I was working on the restructuring of the DGHS for a couple of months just before the talk started, and we could not find the answer that really what is the scope of mandate of the health systems of Bangladesh, because it is not it should be all out approach involving both public, private, and NGO sectors, but ensuring the monitoring and quality assurance and coordinations of these three sectors are quite missing in our health systems. And that is very important nowadays, that we have to work together with strong coordination mechanisms with all these three sectors. The another important issue is that, as Dr. Mustak has already mentioned, that we don't have the population health status monitoring. And without the population health status monitoring, an effective public assistance cannot be developed. And actually, in Bangladesh, we don't have that population surveillance of the health status of the Bangladesh. So that is another important challenges to strengthen the health systems of the country. So the next important issue is the whole health systems in public sector is so much centralized that not managed, it is administered. But we need to manage health services from the all tiers or all level of health services by providing more delegations of activities, more decentralization at the divisional level, at the district level, at the regional level. Because our divisional level is just not planning themselves. They don't have the financial autonomy also, and they are not developing the management as well as human resource development by their own. It is all arbitrarily controlled. So the time has come to address this issue to ensure the universal health coverage for all types of. So this is important that we need to, delegation is very important, and with an organizational restructuring and roles and functions clearly defined. We have to take care of the legal and regulatory framework for the health services. We have not very clean-cut legal and regulatory framework, except for the private sector. There is a 1982 Act, which still remains a lot of improvement, lot of amendments. So we need to review the rules of legal and regulatory issue, because without the correct legal and regulatory issue, we cannot control as well as we cannot ensure quality assurance, quality of the health service. And stewardship is very important. Of course, the government should play a very strong stewardship to improve the health systems. And we have restructuring services, which is lacking in this country. And finally, I like to add one important, very important issue in our health service is the urban health. Urban health is not, because the urban health is not the mandate of the health ministry. Even urban health is the mandate of the local government, and local government does not have the capacity to run the urban health properly. So we have to take very seriously in future that really who is going to take the leadership in urban health program. So thank you very much. With this, I have some just suggestions. Now time has come to work together to get a real reform to strengthening the health systems in Bangladesh. Thank you very much. Thank you all.
Thank you, Professor Shah Munir. We have time to invite two more people to speak. I see that Dr. Faisal has raised his hand. Dr. Faisal, if anybody else wants to speak, please raise your hand at this stage. Faisal.
Thank you very much. I thought of asking a question to Professor Shahidullah that he mentioned that there have been a very poor allocation of money or budget for the health sector. But on the other hand, it is also said that there is a very poor absorption capacity in the health sector to utilize the money properly. So how do you then explain that you want more money with a poor efficiency and utilizing the money?
Okay, we'll have Dr. Shahidul answer to that later on. The next person asking question is Maruf Khan.
Good afternoon, everyone. Yes, sir. Good afternoon, everyone. And I feel privileged to get the opportunity to meet with you all in the same platform. So, and thanks the speaker who already said some important issue. And I also want to add something that this COVID-19 actually exposed the skinny nature of our health system. Actually, as a public health physician, what was struck me that from the early of this pandemic situation, I found that our focus was mainly on the treatment purpose rather than the prevention. And after that, it was very overexposed that there was a incoordination among the different ministries because this is a pandemic situation and the disaster things. So we have no experience that how to deal or how to manage in such situation with a good coordinating with each and every ministry properly. But we found that there is an absence of proper planning. We know that we have many constraints, we have many limitation of budget, and our health system is not up to that mark. So in normal time, we struggle to give or deliver the proper health system to the people of the Bangladesh. But in that situation, in the pandemic situation, we need proper planning. But it was very shocking that we are facing, and we have seen that there was a, I think, absence of proper planning, and there is a less coordination among interdepartmental or interministerial. So maybe in future, in coming days, our health system need to reform or reconstruct, and we need to be paid more focus how to deal such pandemic situation and such disaster thing. I think in the time, and we have many more things to do to reform our health system. And there are many distinguished persons in this platform. I hope in future they will take more care and they will take proper planning and how to deal such situation and who will be involved to tackle this thing. If we said the other developed country, we can say that they prepared a team with all.
If you have to summarize here.
Yeah. So I hope that this COVID actually give a good lesson to us who are involved in the health sector. And I believe that in coming future, we will able to overcome this thing. Thank you all.
Thank you, Maro. Now we move to our next speaker. We'll have more opportunity for question, answer, and comments later in the program. Now we move to our main program, and we are very pleased to have Robert Yates. He is the Executive Director of Universal Healthcare at Chatham House. And Robert is joining us from London. And he will be talking about the implementing universal healthcare in the aftermath of the COVID-19 crisis, and he will be drawing experiences from other countries, the international experience. So these viewers, Robert, over to you.
Thank you very much indeed, Mushtaq, and an absolute pleasure to be with you, calling from London. I wish I was talking to you from Chatham House, but we're in lockdown at the moment. We're all working from home, so I'm talking to you from my study. Just checking that my internet connection is okay, because I'm competing with my daughter who's having a Spanish lesson and my wife upstairs for the broadband. So if there's any problem, I can switch to another network. But it's coming through okay, is it?
Yeah, so far.
Fantastic. That's great. So I'll just share a few slides with you, if I may, and hopefully you'll be able to see these slides coming up now. So have my slides appeared? Just checking that they're there. So
yes, the slides are here. Yes.
So just for the next 10 minutes or so, I'd like to sort of talk to you about about the potential for this COVID-19 crisis actually being an opportunity to accelerate your universal health reforms in Bangladesh. And I think this is a trend that we're seeing across the world. So first of all, you're all very familiar with the picture at the moment. You know, this is a worldwide crisis affecting every single health system in the world. I've sort of picked out the figures from the John Hopkins database last night, you know, suggesting that you're coming up for 60,000 cases in Bangladesh, with sadly coming up for 800 people having died so far. But, you know, the expectation from many countries, ours included in the UK, is that we're not through this yet. And as I say, you know, this is posing a major headache for every single country in the world. And so it's a universal threat, as you were saying, Mushtaq, you know, sort of that requires a universal response. You know, that people are very much sort of turning to their governments and particularly their heads of state to save them from this crisis. This is a time where leaders really need to step up. And it needs a cross-government approach to sort out, in particular, two main areas of interest, I'd say, that if you're thinking about the welfare of families, the things that they want are they want their health protecting and they want their finances protecting. You know, they're worried about their livelihoods. And everyone in the entire country wants this, be they rich or poor, male or female, urban or rural. Everyone wants this. You know, they want health protection, they want financial protection. And they want to see results quickly. You know, that people are under big pressure. Heads of state are under huge pressure to really rescue their populations from this quite unprecedented crisis in any of our lifetimes. And as I point out in this slightly humorous slide, you know, that I feel that this crisis is either going to make or break leaders. You know, this will be the crisis that will define their premiership. And some, like President Macron on the left here, are taking it very seriously and, you know, have imposed very strict lockdowns and, you know, seem to be doing a good job. But as we see in the United States, it's quite the opposite with President Trump. And we're seeing his popularity sort of falling as a result of this. So leaders are very conscious that they have to do a very good job coming out of this crisis. And thinking about those dual areas of people, everyone wanting to have full range of health services, public health services, preventive, curative, and palliative care services as well, but being able to access these without suffering financial hardship, that is universal health coverage. You know, the populations, people the world over are crying out for universal health coverage at this time. They might not be articulating it as universal health coverage, but basically that is what they want. And these types of crises, and this is something I really want to illustrate in my talk, have triggered universal health coverage reforms before. That if we think of the Second World War, when the UK obviously suffered tremendously, the population suffered tremendously, and coming out of that, we were bankrupt, our infrastructure was destroyed, but the incoming Labour government in the 1940s brought in a welfare state providing universal free health and education services as the backbone of its reforms. And this is a picture on the left here of Nye Bevan, the architect of the NHS, literally on the day it was launched, on the 5th of July 1948. We know that day. And what, sort of 70 years later, when we had the Olympic Games in London, you might remember in the opening ceremony, we celebrated the NHS as one of our nation's great achievements. This is the absolute defining moment for the UK coming out of the Second World War, but was exactly what happened in Japan as well. It happened in France too, that they emerged out of that crisis with a very, very good national health system. Another crisis that created a very successful universal health system was the financial crisis in Asia in the late 90s going into the 2000s. And the Prime Minister Thaksin came to power in 2001 and brought in a universal health system. The economy was in ruins. The baht was in free fall, and the World Bank told Thaksin he couldn't afford to do this. But he went ahead and did it. He borrowed money and did it, and it's been spectacularly successful. And the World Bank has admitted that they got it wrong, and have since congratulated Thailand for ignoring their advice and introducing a universal health system. And I think to date there have been something like 57 deaths in Thailand so far in this crisis. The Thai system is doing very well in this pandemic, and everyone is associating it with its well-funded universal health system. In Indonesia, when there was a big change in 2014, President Jokowi promised a universal health system, and it was basically what brought him to power. He'd been able to do this at the state level, at the provincial level as governor of Jakarta, and then came to power very much saying he was going to introduce universal health reforms. He hasn't actually seen through on that promise exactly yet, but I'm thinking that there's a pretty good chance that he will now accelerate these reforms in response to COVID-19. And what all those people did was to basically replace private out-of-pocket spending, particularly on medicines and on consultations and hospital services, with public financing. And that is the key to UHC. You replace private financing with public financing, and you spend that as efficiently as possible, particularly on primary healthcare services. And that is the key to UHC. And this is Dr. Gro Harlem Brundtland, the former Prime Minister of Norway and of course former DG of WHO, at the high-level meeting that Sheikh Hasina spoke at last September, saying that the only way you can reach UHC is through public financing. The private insurance won't get you there. So it's absolutely crystal clear what you have to do. If you want to introduce a UHC system, you need to increase public financing and replace out-of-pocket financing. And this graph that I think I shared with a number of you when we visited Bangladesh in January illustrates this journey to UHC. So countries down here that we associate with a very good UHC system have relatively high levels of public spending, and that tends to crowd out this out-of-pocket spending, which we know impoverishes people. And here's Thailand doing very well now. It was up here before, and it's come down here and is weathering the storm extremely well. And Bangladesh is just starting this journey now. You're aware that Bangladesh, low levels of public spending, high levels of out-of-pocket spending. But my suggestion and recommendation is that with real political commitment, you can move down this curve very quickly. And this illustrates the history of public spending in a number of countries since 2000. And again, you can see here sudden big increases. These are the Thaksin reforms of 2001 too. Interestingly, he didn't actually put that much more money in while he was in office. But then there was another crisis when the military ousted him in a coup, and the population rioted. They were so upset that they thought they were going to lose their health reforms. And the military government very wisely put even more money into the health system in Thailand. This is China responding to the SARS epidemic, massively increasing public spending over the early 2000s to sort of re-socialize the health financing system. Iran huge increases in public spending since 2013. But then countries here not making that much progress, tending to be sort of flatlining at 1%. But then you see Jokowi is increasing public financing in Indonesia. And the suggestion or a recommendation is that if Bangladesh were to follow what these other countries have done, that you could race past Pakistan and India and become real UHC leaders in South Asia. The field is set for, I think, Bangladesh to become the UHC pioneers in South Asia. And just to illustrate that there are countries in this crisis thinking exactly this. One that I would recommend you look at is South Africa, which surprisingly hasn't made the transition yet. This was largely a legacy of the apartheid years. But President Ramaphosa now is very much looking at coming out of this crisis to introduce or accelerate UHC reforms. He's having a very, very good crisis. He's chair of the African Union. He's responded extremely well, getting a lot of plaudits for this. And you can see in this slide, this was only, I think, from, this week, the president says that the government's COVID response is preparing the country for, they call it the national health insurance. It's a tax finance system. They are going to introduce a South African NHS. And I think the real country to watch on this is the United States. For years and years, they've been making very slow progress. President Obama went some way to introducing UHC. President Trump, of course, has come in and tried to blow all that up, but the Republicans haven't got a solution, and I feel that this might be, what's going to trigger the change of government in the United States. 3/4 of Americans now want universal health coverage. Millions of Americans are losing their health insurance as they're losing their jobs. And just even a couple of weeks ago, in a town hall meeting, Hillary Clinton was saying to Joe Biden, this would be a terrible crisis to waste. You heard Dr. Chowdhury at the beginning of our webinar saying this. This is a crisis you shouldn't waste. Now is the time for universal health coverage. So the big question is, will Joe Biden become America's UHC hero? I think he would be very advised to have one of his flagship policies for the November election that he runs on a UHC platform. And therefore, I think the big question is, will Her Excellency Sheikh Hasina emerge from this crisis as Bangladesh's UHC health hero? And I think there's a tremendous opportunity. This is the Prime Minister speaking at the high-level meeting in September. You can see that she's committed to this agenda. With 50 years of independence coming up next year, and I'm sure the nation wanting to have a great celebration, particularly after this terrible year that we've been having in 2020. For me, this is absolutely the logical thing to do, and that were she to come out of this crisis, putting limited public financing into the health system to cover everyone in Bangladesh, that will be an absolutely tremendous achievement, for which I'm sure she would be heralded in Bangladesh, but also in South Asia and right across the world. So thank you very much indeed for giving me the opportunity to talk today.
Thank you, Robert. I wish our Prime Minister was watching this, but of course, there are people in the audience who work closely with the Prime Minister and her office. So we hope that the Prime Minister gets the message there. Thank you, Robert, for telling us the international experience on UHC and how Bangladesh, a country like Bangladesh, can actually learn from that, and that Bangladesh is rightly poised to adopt UHC for the next phase of our journey. Thank you for joining us, Robert. Now, I'm pleased to invite Dr. Fahmida Khatun. Dr. Fahmida is the Executive Director of CPD, the Center for Policy Dialogue. And we all know that Bangladesh is a country which spends the lowest in the world. Perhaps the only country which spends lower than us is South Sudan. So it's a real shame that the Bangladesh spends so little of our money on healthcare. Now the budget is coming on the 11th of this month, and I know that Dr. Famida and her CPD has been working very closely, and also been advising the finance minister and other people on the budget. So we want to listen to Dr. Famida about her take and how she sort of sees the implications of the COVID-19 and the prospect for universal health coverage and its inclusion in the allocation of resources in the new budget. Dr. Famida Khatun.
Thank you, Mushtaq Bhai. I'm really privileged to be here with a number of experts on health issues. So my area, I'm not a health expert, but neither a health expert nor a doctor. But I would like to focus on what you have just highlighted, and some of the speakers before me had also highlighted, that is the expenditure on the health sector. And here I would take an approach which would be implementable in the short and medium term. So since we are also talking about an overall reform of the health sector, so some of the initiatives will be starting in the short term, but will have to be implemented in the medium to long terms. So with regard to our negligible health expenditure in the national budget, the increasing allocation for the health sector is a common and justified demand in case of Bangladesh. And as we have heard before, that we have only an allocation of 0.9% of gross domestic product in the health sector, and also less than 5% of total budget expenditure, which is very little for a country which has a population more than 17 crore. And in the current fiscal year, that is fiscal year 2020, per capita allocation is only 1,537 taka. So if you convert it in dollars, so it will be just about, I think, less than $2. So as a result, out-of-pocket expenditure is very high. So if the health cost is taka 100, government support is taka 34, and the patient has to spend 66 taka. So this may not be a problem for those who are wealthy, but for the mass population who are poor and lives below poverty, even for the low income people, this is a very difficult situation. They find it very hard to finance their health needs. But having said that, I wouldn't also undermine the achievements which have been achieved by Bangladesh during the last decades or two decades, because we know of the fact that during the Millennium Development Goals, many of the indicators, social indicators, including the health I think, sorry, I think I was, yeah. So.
You are okay now.
I'm okay now. Yeah. So I don't
yeah.
know how far you could hear me, but yeah, just what I was
seconds,
yeah, what I was telling, that the achievements, for example, if you look at the life expectancy rate, which has reached to 72 years in 2017 compared to 65.2 years in 2005. Infant mortality rate, which was 50 in 2005, it has reduced to 24 per 1,000 live birth. So some of the other indicators are also doing quite well. And of course, this has been possible due to a number of initiatives and measures and policies which have been taken by the government, and also the private sector, non-government organizations, development partners, all have contributed towards that. Here I would like to mention about the National Health Policy 2011, which recognizes that health is a right of citizens. And this policy aims to achieve better health for all and strengthen primary health and emergency case care for all. So this also advocates an equitable access to healthcare by all, irrespective of gender, disability, and poverty situation. So the other initiative I would like to mention here, that the Health, Population and Nutrition Sector Program, which is covered for the period from 2017 to 2022, that aims to move towards universal health coverage, which we are discussing, and the previous speaker has really eloquently highlighted this initiative taken by many countries successfully. And so this HPNSP, which is the program, that also aims to achieve the health related goals which are mentioned in the Sustainable Development Goals. The other important policy or initiative is regarding the financing, which we are discussing, that that is the healthcare financing strategy, which is for the period for 2012 to 2032. So this has the objective to reduce the out-of-pocket expenditure and reduce the out-of-pocket expenditure by in fact, from now it is 66%. It is the objective is to reduce to 32% by 2032. And the other objective is also that to increase health budget, increase it to 15% of the total national budget, which is now only less than 5%. So these are some of the policies. So if you talk about policies, that we would say some of the very good policies are there, and some other good initiative, for example, that community clinics, which are the initiatives to bring primary healthcare services to the doorsteps of the people in the rural areas, is also a commendable initiative. But we also know one of the speakers previously asked a question, that we also know that expenditure or the budget is only one part of the solution of the health challenges, because there are larger issues in the health sector. For example, what is the quality of the expenditure, and who gets of that expenditure by how much is wasted, what is the human resource situation, what type of management, what are the regulatory and governance issues here, and what is the accountability mechanism. So these are all related to the health expenditure. And since currently the health outcomes across various sections of the society indicates that that everyone does not benefit from the expenditures equally. So we are asking for an equitable public healthcare system. And as I mentioned, that during the COVID-19, that has been the focus of our discussion, and this is really an eye opener, that how little we spend and how neglected the sector has been so far, despite the fact that the size of the budget is increasing, despite the fact that the country is progressing in terms of economic growth. So budget is one part. The other part is the management, because we know that shortages of doctors, nurses, midwives, technicians are acute. So, for example, if you take the number of registered doctors, so there is one registered doctor for 1,581 persons. So which is really a dire situation. And also the vacancy rate of doctors in rural areas, remote areas, and hard to reach areas is very high. Absenteeism is another common feature, though I know we have the policymakers have been trying to attract the doctors to the villages, to the rural areas, but it is very difficult. Even after a stern directives from the highest authority, it is very difficult to keep the doctors. So it's not only higher salaries, but also it is the other facilities of the areas where they are posted. So public amenities, good education, all these are very important. So the health system in the remote areas cannot be developed in isolation. It has to be developed in conjunction with the development of other sectors. So that is one of the realization. And so the development of local economies and development of other amenities is very, very important in order to have a good health system in the remote areas. And so this is also related to the bigger issue of decentralized development policy, which is absent at present. And we also see that in many public hospitals, equipment is available, but we see that the positions of technicians are not are vacant. So recruitment and retention, these are also very important. Equally important is the training and development of health workers. Now, the actual benefit for budget allocation by patients is low because we know that a significant part of the allocated resources go for physical infrastructure development and for salaries and allowances. So by development of the health sector, if we mean that we have good infrastructure, good buildings, good hospitals, that's one part, but the quality of the services, the quality of health services, that's more important, which is absent at the moment. And also related to that, related to the allocation for budget, health budget, is the issue of corruption, is the issue of misuse and wastage of resources. For example, procurement is an issue. I mean, so that is something where a lot of resources are wasted. And procurement and budget for construction for infrastructure are often the sources of misappropriation of the health budget. This is so when we talk about increasing the allocation for budget, the quality of expenditure is also very important, and also the capacity of the related institutions, the health ministries, the departments, because we see that now the budget for the next fiscal year 2021, is being prepared. And we have seen in the media, a lot of reports have come that in view of COVID crisis, there is a huge demand for increasing the health budget. But we also know that the capacity to spend by the health ministry is really very poor, because during the first 9 months of this fiscal year, current fiscal year, the health services department could spend only 26.7%, and health education and family welfare department that could spend only 24.94. So about 25 to 26% their expenditure capacity, whereas the national capacity for other projects that is also very low. In Bangladesh, we know that a lot of annual development programs are not implemented, and we always lag behind. So the national implementation rate for projects has been 45%. So here for the health sector, it is almost half. So we can see that the capacity of the health sector is so low. And if you have lower capacity to spend, the finance ministry, even if they have the good intention to increase the health allocation, they cannot do so, because they have to rely on the record of the capacity of spending. So if they base their allocation on the expenditure of the past years, then they have nothing to do. So this is really a vicious cycle, you can say, that the allocation is low, and then implementation is low, and then again next year the allocation is low because the implementation has been low. So if you really want to get out of the system, we really have to improve the capacity of the whole health sector. So there are a number of measures we have, and some of these I have touched, but the whole issue of reform of the whole the health sector is required. Now, we also now know that alongside the public healthcare, there are private healthcare system. As the country is growing, the economy is growing, the private healthcare sector is also growing, and there is a section of people who can afford these private healthcare services. But again, these private healthcare services should also come under the regulation of the whole public healthcare system, national healthcare system, because not all the private healthcare services are of good quality. We all often hear about the mismanagement of the private healthcare system. Just a few days back, in one of the private hospitals, how the fire broke out. So that is another indication that even the high valued, highly expensive hospitals can suffer from mismanagement. So these should be also accountable to the whole national healthcare system. So this is the other issue I would want to touch is also that the allocation for research, advanced research in case of health. As it is in the national budget, we see the allocation for research and development in all areas, not only health, be it for education, be it for agriculture, for other sectors, it's very negligible. But health system is something where it demands a higher allocation for health research. The other area is the issue of data, because we see while dealing with data, dealing with various aspects of the social sectors, we always struggled with the lack of data in case of health, because real-time data is really not available. And if we do not have real-time data and disaggregated data on healthcare, we don't have the understanding of the state of affairs in the health system. So data limitations also constrain the research and the analysis of the health related issues. And more importantly, quite often it may give a wrong signal. So updating the data and availability of real-time data is very important for the healthcare system if we want to really devise any policy in this area. And in conclusion, I would like to emphasize that COVID-19 crisis has testified that how ill prepared we have been to tackle the health crisis in general, in normal situation. But COVID-19 has multiplied the need for massive healthcare facilities. So the limitations are evident in many areas, from facilities such as testing kits, ventilations, hospital beds, number of doctors, intensive care, etc., etc. So this surely indicates the need for a higher investment in the healthcare system. Without much more investment by the government, affordable and accessible healthcare for all cannot be ensured, and the inequity in healthcare outcomes cannot be reduced. And if we really want to sustain the economic growth which we have achieved during the last few decades, the country cannot really provide universal and good quality healthcare services to each and everyone. And we also know that the COVID crisis has also revealed our weaknesses in management and coordination capacity, because not only the investment, but the management and coordination has to be also improved. So the improvement of the health sector should be looked holistically, not just in terms of allocation, not just in terms of only management, but overall sector has to be looked together with a broader lens. I think with this, I would like to end my talk. Thank you very much.
Thank you, Fahmida. You have touched on a wide range of areas, starting from the governance and management of healthcare, and of course, even on the issue of the shortage and problems with research and data. But obviously, you also talked about that there is a real issue of lack of money. But at the same time, you were also asking questions of the real question is how whatever money we have, how this money is used. So these are all very pertinent and very important question for us to move forward into the UHC situation. So thank you very much for that. Now we have a few minutes of for discussion and question answer. So we have a number of hands raised, and I will ask all of you to say in 1 minute. And I will start with Syed Abdul Hamid from Dhaka University. Dr. Hamid, you know that in the earlier discussion part, there was a question about the absorptive capacity of the Ministry of Health. And I know that you have been doing a lot of research on this particular issue. So if you can sort of say a few words on this question of the absorptive capacity, that will be very helpful for the audience and all of us.
Thank you, Mustak Bhai, and for arranging this webinar, and also thank you for inviting me. Let's start from a good news, because we know that we are all in going to the bad news. So the good news is, you know, that Dhaka University Authority has finally decided to introduce health insurance for all the students. So I think this is a milestone. This could be a milestone for the nations. So if the Dhaka University starts, maybe the other university will also start, and if this process going on, so maybe within 10-15 years, that the social health insurance in the national level could be introduced in the countries, because these students will be in their career. They will be the prime minister, they will be the finance minister, the health minister, also the health secretary, finance secretary, and many other things. So I think that they will carry on to introduce health insurance for all the citizens in the country. So let's come to your questions. Basically, what my understanding is that you know, we have the managerial severe lack of managerial capacity to ask for the budget and also for spending the budget. Why I am saying is that, from the very beginning, in the TSFPO, in the Upazila Health Complex, and on the district level, the civil surgeon, you know, so they basically doctors do not want to come in these administrative positions. Even they do come, they see that they do not have the career path. So they do not build themselves as a good administrator. And we know that they cannot be promoted in the higher position in busy health and also in the ministry. So that is why they do not grow as themselves as a good administrator. So they do not acquire the educate capacity to ask the budget and also for spending the budget. So we need basically a complete reform targeting to change this managerial capacity, you know, and that is why I think we should not think it as a piecemeal basis. We need to have a master plan for all these changes. Hamida has raised some good points. Roberts has also raised some good points. So what I believe is that we need the complete reform in the managerial capacity and also in the other areas to basically spending the budget in quality way and also ask for the more budget. Basically, that the health sector manager do not know what is their need. And why they do not know? Because they do not have, again, I am speaking again and again, that managerial capacity. They need to understand what is the need of the health sector, what is the need of the hospital. There's many things are responsible for this, but if we try to identify this, we need to have a master plan, and before that, we need to have an act, and before that, and after an act, we need to have a health commission or national health commission or something like this. So if we go in this way, that means the health sector have the good days. If we think is very piecemeal basis, this discussion will be continuing the years after years, and no change will be coming to the health sector. Thank you very much, Mustafa.
Thank you.
স্যার আপনি কি আছেন স্যার? স্যার
কাকে বলছেন?
স্যার মুশতাক স্যার, মুশতাক স্যার।
Sorry. The next speaker is Syed Rubayat. Rubayat, you have 2 minutes.
Thank you. I think what I understand from the discussion is that there is a vicious cycle, and that vicious cycle is the capacity of the health system management's capacity of utilization of budget and allocation of budget. And our domestic government expenditure for health is only 0.38% of our GDP. 20 years back, it was like 0.58. And each and every year, our out-of-pocket expenditure increase, and we are not investing on our health system to improve the capacity of our health system, improve the capacity of the health system management system, and we never give focus on improving the capacity of the district health system. The district health management structure, which is at present exists, is what it was during the British rulers. And over the course of 70 or more years of time, the health structure increased 20 to 50 times even in a district, but we have the same number of health managers in a district, like 2 medical or 3 medical officers and a civil surgeon and some junior staffs. And we never invest on them to build their capacity and then appoint them as a management person. So this is one major challenge for health system, because they have very, very little resource to utilize. And why it is happening? Because health is not a political priority in Bangladesh. If you look at the last elections manifesto of all the parties, you will not find more than 2 sentences in their manifesto regarding health. So how we can expect that the health will be prioritized in our budget, in our political priority, though it is mentioned in our constitution. So this is a major area where we need to invest our energy, our combined voice to prioritize health. We need a new health system, a revolutionary change in the health system, and investment must need to be increased. And we always share that our GDP health expenditure is like near to 1%, but it is including our out-of-pocket expenditure. Government health expenditure is only 0.38% of the GDP. So
thank you.
We need to move with more advocacy, and we also need to acknowledge the reality. The BMMS, the BDHS, health facility survey, all the recent surveys providing us clear indication that we are not moving forward with a positive direction of health status, with survival rate or quality of care. We need to acknowledge, we need to come out from the denial and move forward jointly with the advocacy for prioritizing health in our national program. And last of all, I would like to also seek attention from everyone that we know after 1918 pandemic, there was a baby boom happen worldwide, and we should prepare ourselves, whether early prepare can avoid that or late preparation, we need to prepare ourselves to welcome these babies. Thank you.
Thank you. Thank you, Rubaiyat. I'm afraid we will be running out of time very soon. We still have 2 distinguished speakers to speak to us, but I want to give floor to 2 more people. And Zahidul Qayyum, if you can say what you want to say in just 1 minute, please. Zahidul Qayyum.
Thank you, Mr. Mayor. Just in in 1 minute. Actually, there was very interesting point that has been raised, starting from Robert, which is very political economy in healthcare. That was really very good and bringing some of the issues. I just want to bring one particular issue. We were talking about the budget. We want to move to the universal health coverage. One issue is like, okay, we don't have sufficient, but the issue that came around that, okay, but the capacity of the absorbing capacity of that money is not there. My only point is, and of course, if anybody can throw some light on that, that we are not allocating the resources where we need most, and that's not being done following a very standard practice, successful practice. And of course, I also know that doing some of my work, my interest also said that there has been some policy, but again, it needs a political commitment. Of course, people from the government they would very well on that. The other thing I just want to bring that issue that. Yes, of course, we know that it has to be publicly financed, and it's very close to my heart. And an issue is like, what's important thing is like how we can do that. Totally public financing and public provision, and how we can bring in, even if it's public finance, and bring the private, and what are the mix, and how we can really do that. What are the conditions, and what are the scenario, what are the infrastructural, the institutional arrangement we need to make on those reform areas. The other issue, and that's very important thing we just would like to mention is like.
Zahid, can you sum up, please?
Yes, right. Okay, I'll just bring these 2 points, and that's kind of just that's fine. Thank you.
Thank you. Our last discussion today is Romana Hawk. I'm sorry that there are a few other people who want to speak. I won't be able to give them time, so I'm really, really sorry. Romana, you have one minute.
Thank you, Mushtaq bhai, for giving me the platform and with these distinguished guests. So I will highlight a few issues which we are saying since 2013 in different rounds of annual program review, midterm review, and other strategic investment plans. And my question will be, despite having these written in all those reports, why we are not still doing it? So it's maybe the right time to focus on. One is needs-based resource allocation, doing the district level planning, assess the need within that district, and then decentralizing, giving more autonomy at the district level for financial resource utilization and planning. Developing capacity, already mentioned, but just want to highlight procurement process need. Still, after 22 years of sector-wide approach, we need training on procurement process, developing the operational plan, developing the program implementation plan, how the results framework is linked to the budget, and how the entire resource disbursement is linked to the indicators. All these needs greater understanding, and also the auditing. Half of the time of the health professionals at the central level goes solving audit reports. Every year we are saying so. We need to solve these. Health technology assessment, Ashad sir's dream for last couple of years. I think it is time we really focus on health technology assessment and set up the process of regular health technology assessment. Another demand was creating public health cadre system within the health sector. So time to negotiate with the respective ministry so that we at least get one person at the district level as public health expert, and also at the central level, we need lots of public health experts. When we did the sector-wide approach, we wanted greater coordination, but still why we have NCD corner, maternal health corner, child health corner. So how we can tackle the multimorbidity. So that needs to be taken care of. So I'll stop there. Thank you very much. Just last note is, in next 20 years, elderly population will be higher. Now we could not, if we cannot take the demographic dividend, it will be really difficult to manage those majority of the elderly people in next 20 years. So it is the time that how we can solve the future problems and create a long-term plan. Thank you.
Thank you, Romana. I know there are several other people who want to speak, but unfortunately we are not able to accommodate that. We are really sorry for that. Now we have two more speakers, more distinguished speakers. And I now turn to Dr. Hussain Zillur Rahman, whom we have requested that he sort of gives his own views about how to advance UHC in Bangladesh, and also do some sort of summarizing of the discussion that we have so far. So with these words, over to Zillur.
Okay. Thank you, Mushtaq, and thank you for this very important webinar on the health system reform in Bangladesh. I think much of the discussion has been, if I want to extract some signaling language here, one is the word I think is relevant here is the word urgent. Things are urgent. Has to be a sense of urgency. It cannot be a business as usual type of discussion where we go through a lot of analysis, etc. And as everyone has underscored, I think much of the solutions have been talked about for quite a long time. The last speaker, I think Rumana was mentioning since 2013, many issues have been repeatedly been mentioned. So I think how do we bring this sense of urgency? It's not like we don't know the solutions. Solutions have been thrashing around for a while. How can we create a sense of urgency? I think this is a very, very important issue. But nevertheless, in terms of at the level of perspective, I would like to just highlight still beyond the issue of urgency, at the level of perspective, I think some additional points have come forth and I would like to add a few more. One is, I think the word, efficiency has been used in terms of management capacity, system, etc. But I think another area for the efficiency analysis is why is the out-of-pocket expense so high? It's not high only because public investment is low. It's high because of the nature of the expenditure itself. Why, for example, is the price of medicine out of control? Right now in the pandemic, it's not just that people are suffering from the infection, but a 10 taka medicine is going for 700 taka. How is that possible? Other equipment type have gone 100 times the price. So I think we have to really get a handle on this, that getting rid of OOP burden is not just going to happen through increasing public financing. We have to look equally at the issue of efficiency here. We have to ask the question, why is out-of-pocket expense so high? Much of the unnecessary tests, unnecessary examination fees, etc., the so-called dalal fees, etc., which are active even now. So I think that part of the argument needs to be looked at. It's also a governance issue, but I think it's a very important issue that we ask the question of why we are not achieving cost efficiency. Cost efficiency has to be a critical part of the OOP reduction agenda. It cannot just be the public finance expansion agenda. So that I think has to be kept in focus. Second is yes, public finance obviously has to be expanded, but I think even here it has been touched upon, but the figures are rather compelling in terms of looking at the item-wise examination of the allocation. Even this budget, it is going to be proposed on the 11th. If you look at the health sector allocation, 33,000 crore taka, I think, roughly, which has been the health budget, out of which I just did a quick calculation. The vis-a-vis the development expenditure, which is essentially which goes on concrete and other things, the manpower expenditure is about 4% vis-a-vis the development expenditure, and the research expenditure is 2%. So you have an imbalance, and there is actually a physical image to go with this imbalanced public allocation. I think Fahmida also mentioned about the item-wise inconsistencies. The physical image, you go out to a district, you go out to Upazila, and you have a so-called 250-bed hospital, a 500-bed hospital, but operating at 50-bed hospital capacity, because the money was quickly disbursed for the concrete, but the money wasn't forthcoming about the manpower, the appropriate amount of attention to the soft areas of the expenditure. And this is going on and on. I think we cannot just expand the public financed health budget to just put up more concrete, which doesn't deliver healthcare. I think that is a critical issue we have to look for. We have to argue for balanced expenditure here. I think this is no question that health ministry cannot get the public administration ministry to approve their health manpower plan. This is not on actually. We have to put a stop to this issue that on what ground, even I think the proposition for a new hospital in a district or in Upazila should not get the go ahead unless we have both the manpower part and the concrete part simultaneously approved. If we don't do that, then we have actually what we'll have is this 500-bed hospital, which are offering the services of a 50-bed hospital. So I think that's a critical issue that we need to look at. This COVID-19, I have seen one of the key weakness, people have mentioned about management capacity, lack of coordination and all that. A critical area of weakness we have seen is, I would in fact not just call it a weakness, I would call it a failure at some level, a communication failure of the type of messages which should have gone out to the people. We haven't really, the communication is a critical part of public health. And I think getting our capacity to deliver good, effective, usable communication is important. And we have really mixed up the messages that we have given. For example, even we haven't used the word lockdown, we have used the word general holiday with restrictions. All of these sort of language are open to variable interpretation, and people actually have interpreted them in a different way. So I would say that going forward, this capacity on effective communication is one of the capacities that we must really focus on. And two other points, and then one is that I think it's very interesting that we have rightly taken pride in the fact that we are, it's a pluralistic healthcare system, government, NGOs, private sector. But COVID-19 crisis has shown up the weaknesses of particularly the private sector. It's not a surprise, or it's now well known that how non-corona healthcare has completely dried up, not even if not completely, largely dried up during this crisis. And it is an issue that private healthcare, I think the governance of this is a very important issue. We need to not just get the bureaucrats in control of the private sector. That's the farthest thing that we should be advocating. But an effective governance of the private healthcare system is a call of the hour. United Hospital with its fire and then charging one of the victims with a huge cost is an extreme example of governance failure of the private healthcare system. But I think instead, not just focusing on the sensationalist sort of aspects of it, but as a whole, we have to get the private healthcare system, the governance of it in a very effective manner. And here, I think the issue of corruption cannot be downplayed. It was briefly mentioned by a few. I think part of the reason why people have used the word corruption, some have used the word vicious cycle, meaning that the capacity to absorb. Hamid has told us that about a quarter of the funds allocated could be spent before COVID struck. That gives an example of the level of capacity within the health ministry. So there we need to really look at how we can enhance that capacity. It is both the issue of corruption is a very important issue. The capacity absorption, how do we improve that? And here, I would be really, I would prefer to get angry rather than frustrated. We have to get angry. Why are things that we have been telling for years and years, why are they just gathering dust on the shelves of ministries, of departments, and of our own offices? Here, I think it is very important that reform ideas, and I think here, to be fair to the public authorities, Minister of Finance, etc., it is a case, some people have mentioned this, that compelling case for the reform agenda has to be prepared actually. Compelling case has not yet been really, we have to prepare that compelling case. Robert Yates mentioned about Thaksin, about other places there. I think I had a look at the Thai experience. I think Thaksin was able to act on it because the health sector professionals had completed the job of preparing that compelling case. We have to actually do that in the Bangladesh case, not a generalized reform agenda, but a compelling case of exactly where reforms are necessary, how they're going to be done. And here, I would really give voice to what Hamid has been pushing for a while now, is that it is not enough just to talk of a reform agenda for this sector. We have to also talk about the reform driver. Who is going to drive the reform? Hamid has mentioned about the possibility of a health commission. There is a similar thing in Thailand actually, and perhaps in other places also. Not just a reform agenda. We have to also talk about the reform driver. We have to get a reform driver within the system. We cannot just leave it to the health secretary or some technical committee within the ministry, because they have not really stepped up to the job. I mean, I'm extremely sorry to speak in such frank terms, but I think we will not get much far unless we are frank, because we all collectively want the whole system and Bangladesh to really move to a better place. We want a reform driver. What can be a good reform driver? The idea of a health commission, a high-powered health commission, is one idea that one can think about. We should really look for that. But these ideas, I know that in the Bangladesh context, reform ideas to take root, it's a difficult environment in which serious reform ideas can take root. Meanwhile, Bangladesh has really, one of the strengths of Bangladesh is that we have really moved ahead on doing some intermediate but very effective steps also. One step that two steps I would suggest, and then I would end, Mushtaq, on my intervention. One is that while we are trying to get these reforms in place, let us at least prioritize two agendas, which must happen right now, both in terms of money and in terms of specific steps. And some groundwork has already been done. One is urban primary healthcare. This is critical. And I think some groundwork has already been done about urban primary healthcare. And we can go ahead on a fast track on this issue of urban primary healthcare, which is both preventive, but also can be the base for an effective referral system. I think that's a very important one that we should move ahead. Second one is the issue of the health agenda should not just be about the healthcare agenda. It has to be the public health agenda. I think public health expert Rumana Haq mentioned about that. But as a whole, we have got stuck in the bureaucrats' turf battles of who will do it. Is it health ministry or the local government ministry? Public health is more perhaps currently in the Bangladesh context, the domain of the local government, the municipalities, etc. We need to bring the public, particularly the hygiene agenda, the public health agenda, the waste management agenda within this discussion of the health agenda. Because in the going forward, the COVID-19 has mentioned it's not just why are you washing our hands? Why are you doing social distancing? It has to be about also the public health issue. It's about this hygiene issue. And that traditionally, I've looked at the WASH budget. We are doing a tracking of the WASH budget for the government of Bangladesh. And there we see that allocation on the health subsector, hygiene subsector is minimal, almost non-existent. So we have to reverse those subsectoral allocation imbalances and really look forward. So going ahead to Certainly the bigger reforms, we have to take that into account. We have to have a reform driver. We have to build the case for the reform. Meanwhile, while we are doing that, we must establish the urban primary healthcare system in the short run. Actually, we should get going even in 2020. We should hit some really good steps ahead. And let's also get the municipal public health issue within the discussion of health and make a big also budgetary allocation there and try and get our go ahead. And there, the whole issue of health as a healthiness itself has to be an agenda actually going forward. I think COVID-19 has shown us that immunity is what is going to save us. Vaccine certainly, but immunity is also a very important concern here. And how do you build that immunity? There, I think thinking about health in this larger sense. I will end on that note, Mushtaq, that health is, it was also before, but in the COVID-19 context, health cannot be left to be a sectoral agenda. It is the strategic agenda of today and tomorrow. And that without health, you will even not get the economic recovery that we are so desperately wanting. We have to accept the strategic nature of the health agenda and act accordingly. Thank you, Mushtaq.
Can I just, Mushtaq bhai, can I just say a few things?
Sure, sure.
I have to leave now. I need your permission because I have got a prior commitment.
Shahidullah bhai, 1 minute মধ্যে
No, I need to leave. I mean, so that's why I'm taking your permission.
ও আচ্ছা চলে যাচ্ছেন আপনি?
I have just another program from 6:45.
Oh, I see. Thank you, Shahidullah bhai.
And thanks everybody. I think I learned a lot from the very good deliberations from many learned participants.
Thank you for joining us and all the best with your technical committee. Thank you. Thank you, Zillur, for your very candid opinion and your observations. Obviously, as you said, that the health has to be part of a strategic agenda, not a health agenda as such. And in order to build the future health system, what you said is that we have to really build a compelling case for us to take us into the new kind of health system that we are talking about. Thank you, Zillur. Now we have come to the final part, and we have our Senior Secretary, Mr. Asadul Islam. So we want him to sort of give his opinion and his vision of how do we take the whole agenda of universal healthcare into the future. And we know that he's a champion of universal healthcare. And he has been in the health sector almost all his bureaucratic life, if we can call it. So he knows the health sector very well, and also that he was the head of the health economics unit and many other very important positions, and finally the senior secretary for health services. So with these few words, I sort of urge upon Asad bhai to say a few words on how do you go forward. Asad bhai.
So possibly he has left because he sent messages in our message box that he is an urgent and important issues that he needs to attend. So maybe he has left.
Oh, really?
So check the message box, and then he said so maybe he has left. So.
Oh, sorry, he had to leave. But we are so happy that he was able to join us. Now we are into. We have already passed our time limit, and I don't know if anyone from the Bangladesh Health Watch working group want to say a few words, final words. I know our advisory board member Farooq Ahmad, he wanted to say something. Farooq, you want to say something in 1 minute?
Mushtaq bhai, sorry,
Yes.
I'm from RDRS. If you
Can you hear me?
At the
Yes.
end, give me allow me 1 minute at the end, Farooq bhai and Mushtaq bhai.
Okay.
Farooq.
Can I speak now?
Yes. 1
Okay.
minute.
Thank you. It's okay. I've been listening, and it's quite knowledgeable. I have met so many friends. Let me give one example, and I perhaps tend to disagree with some of the comments about the absorption capacity and the slow pace of the Ministry of Health. I will give an example. In the late 70s, when I was working as a small officer in the Ministry of Health as an information planning division, and there was a allocation of $45 million first project of the World Bank with co-financiers, could not be spent in 7 years. Late Dr. Sattar was the secretary, Tawfiq Ali was the deputy secretary. I was an officer in that ministry. And the government asked for $250 million, the second project. And the argument was the place that our absorptive capacity was small, was minimal because the country is fragile and we just had the war. So the country was building its both human and physical infrastructure. Country argued for the second project and they could spend the money. So what I agree with what Hussein Zilur just mentioned, this is a sense of urgency. Now is the time, and three things I would mention. The first thing is the political commitment. The government at that time in the 70s made the political commitment for family planning, and they were driving it with the human and physical resources and financial resources to speed it up, and we have got the dividends down the line. So I would say first is the political commitment, second is the more funding, and third is definitely a committed dynamic leadership in terms of human resource at the helm of the affair with an accountable system in place and supported by a maybe a technical advisory group drawn from private sector, public sector, and academia could guide the government how to move on. Perhaps this is the time to go ahead with the health commission, something like that. So the urgency is a very important thing here, and now is the time. Perhaps I don't agree with an intermediate approach now, because the intermediate approach will slow down. We have seen all the bureaucratic hurdles. It was there in the 70s, 80s. It is still there. So we have to make that political commitment this time, and it will come only from the head of the government, no less than any at that level. So how do we really go at that level to make that political commitment with an increased resource and then a dynamic leadership? Thank you very much.
Thank you. I'm afraid we don't have time for anybody else, but there will be other webinars in the future. I'm sure you will be able to provide you more time to share your thoughts. Zilur has very sort of succinctly summarized the discussion, and I'm not going to say anything on the deliberation. I think the whole webinar went very well with the participation of everybody. Particularly, I want to thank the speakers here who sort of spoke from their own experience, and the Bangladesh Health Watch is very grateful to all of you for giving us time, and also to all of you who have joined in this webinar. And we hope that this webinar leads to new areas, what Hussein Zilur was saying, a kind of creating a compelling case for universal health coverage and health sector reform. So with these few words, I want to thank all of you again for joining us, and we hope to see you again before long. Thank you.
Thank you very much. Thank you, Mr.
Thank you very much, Steve. Thank you.
Thank you.
Thank you.
Hi, thank you.
Thank you.
Thank you, Rob.
Bye.
Thank you.